Hello all, and welcome to another episode of Orthodontics in Summary. Today, we're having a look at the lecture entitled Orthodontics in Periodontally Compromised Patients. This was a lecture given by Morten Laursen. Now, his lecture had two components to it. The first was a general consideration of that periodontally compromised patient and what we need to bear in mind. The second were two specific mechanics to common presentations of patients who have had periodontal disease. And they relate to two papers that he published in 2017 and 2020. So Morten started by describing why do patients who have had periodontal compromise come to our clinics for orthodontic treatment. He described aesthetics as being their main motive. Patients who have had periodontal loss start to generate malocclusions, malalignment of their teeth mainly, but also over-eruption of their dentition and an unsightly increase in the overjet. And this plays back to Profit's theory on equilibrium from 1978. Reduction in periodontal support changes the equilibrium, consequently teeth start to migrate, and this occurs at a later stage and age for patients. Morten went on to describe what are the risks of us not factoring in periodontal management for orthodontic treatment. He described three key things. The first is that the force is increased for these patients when they have orthodontic treatment, and has two consequences. The first increase in the force occurs due to the reduction in periodontium. There is less area of periodontal ligament for the force to be spread over. Consequently, there are higher forces and an increased chance of root resorption. The second point is there's an increase in force due to apical migration of the center of rotation. There is a greater moment produced due to this increase in distance from the center of rotation to the application of the force on the bracket and the crown. That results in an increased chance of loss of anchorage in the patient's biomechanics. And the third key factor, if the patient has active periodontal disease, well, the orthodontic treatment is not only going to accelerate the loss of periodontal tissues, but it's going to increase the quantity of loss as well. A study looking at 5-year follow-up of orthodontic patients showed that there was 47% of patients with recession defects. So the main part of the lecture was to describe two treatment mechanics. The first was a protocol for intrusion of the dentition using mini implants as indirect retention. This occurs when the upper incisors and lateral incisors have over-erupted and the canines in an ideal position. So how does it work? Well, the 4 tads that were placed, 1 in each quadrant. They're positioned distal to the canine tooth. They're indirectly ligated using a long ligature from that tad, distal to the canine, to the bracket on the canine tooth. Now, what does this achieve? Well, it means that canine can't move in either a vertical direction or an anterior-posterior direction, thus allowing intrusion of the upper centrals and laterals to the same level of the canine. Avoids the reciprocal effects to that canine taking place. Now, this force system does have consequences. There's a chance of the upper incisors proclining. So what Morten would do is attach power chain from upper canine to canine to prevent that process from occurring, or using a long ligature. The second, the posterior consequences of this force system is distal tipping of the premolars, and that can be resolved or prevented through indirectly ligating the tad now to the actual premolar itself. Now, a clinical pearl that he gave here was when placing anterior tads, if one palpates the roots anteriorly, it will show them where to position the tad in between the anterior roots. So what was achieved here in this particular mechanics? Well, absolute intrusion of the upper incisors of 3 mm. Carried out in the lower arch, it achieved intrusion of 2.5 mm. Now, the second protocol related to individual tooth torque requirements using an auxiliary archwire. This occurs where there's one lower incisor with little bone, and we want to lingually torque that root back into the soft tissue envelope. Why use an auxiliary? So, Morten described that if we use continuous archwire mechanics, there is a challenge that we can get reciprocal anchorage loss in alignment, so therefore an adjacent tooth may also get pushed out of the soft tissue envelope, and when we're torquing the tooth later on, we may have adverse effects on other teeth. The advantage of using the auxiliary in this case is that the adjacent teeth are not involved in the system. So what's the setup? Well, there's only 3 attachments. There are molar tubes on the first permanent molars, and there's a bracket on that affected lower incisor. There is a base archwire of a 020 stainless steel, and that's there to prevent any adverse effects occurring, both in the anterior posterior and the vertical. So how does it fit in? Well, that 020 stainless steel is positioned incisal to the lower incisor bracket and ligated. Now, the active auxiliary archwire is a 1925 TMA. It's activated by being bent down in the anterior segment or with a reverse curve of SPI. And the idea is that this wire is then activated by engaging it into the lower incisor bracket. It therefore has lingual crown torque inbuilt into it. This achieves the lingual crown torque to move the tooth back into the bone. And there's a case series from 2020 which demonstrates this in the AJODO. So the concluding comments from Morten was that orthodontic treatment allows greater cleansability for periodontic compromised patients. It potentially reduces periodontal pocketing depth, as shown by Melson in 1988. But the long-term consequences of having orthodontic treatment mean that we can rehabilitate the degenerating dentition. We can idealize the position of teeth, so when teeth do fail, they can have the ideal prosthesis in both the anterior posterior and in a vertical dimension. Describe the advantages of interdisciplinary care being the key. The more eyes we have, the better results, the more we learn. I enjoyed this presentation giving specific clinical advice for common scenarios.